Okay, everyone, I think we're going to begin. So welcome to this month's Climate, Environment, and Health monthly webinar series hosted by the MGH Institute for Health Professionals Center for Climate Change, Climate Justice, and Health, the MGH Center for Environment and Health, and Brigham and Women's Hospital. It is a great pleasure to introduce today's speaker, Dr. Alexander Wilkinson. I know I've learned a tremendous amount from speaking to him myself, and from his robust body of published work that's been critical in bringing attention to the environmental impact of metered-dose inhalers. So Dr. Wilkinson completed undergraduate medical training at Cambridge University before qualifying in clinical medicine from Oxford University in 2005, and he currently works clinically in Hertfordshire as a respiratory consultant. Dr. Wilkinson works with the British Thoracic Society on sustainable respiratory care, and he's a member of the NHS's Inhaler Experts Working Group. He's a chapter lead author for the United Nations Medical Chemical Technical Options Committee as an expert on inhaled therapies. So it's a real pleasure to have you here today, Dr. Wilkinson. Thank you for joining us. I'm going to turn it over to you.
Thank you very much for that generous introduction. Yeah, it's great to be with you and reaching out across the pond. Can you see the slides now?
We can.
Great. So yeah, I'm going to be discussing really how we can reduce the large environmental impact that we see from inhalers, in particular the propellant gases in the metered-dose spray inhalers, whilst at the same time improving the quality of care we deliver and reducing the massive over-reliance on reliever inhalers that a lot of our patients have. I think these are some of the biggest challenges in respiratory care at the moment, but also a key priority if we're going to reach net zero within healthcare. I've got some credentials and conflicts of interest, but Greg's kind of been through most of them already. I have indeed somehow managed to get a job with the United Nations, so I do have to pinch myself when I say that to make sure I'm not imagining it. I have worked with some pharmaceutical companies as well, as listed there, but I never received a penny from them, and I'm keen to maintain my impartiality because of my other roles. So I've titled the talk A Green Challenge and a Golden Opportunity because I do think there are enormous possibilities to cut greenhouse gas emissions at the same time as improving patient outcomes in asthma and COPD. And why such an interest in inhaled medications? Well, specifically, a lot of the focus is on these pressurized metered-dose inhalers or spray inhalers. And these inhalers have to perform quite an extraordinary job, really. Within them is a pressurized canister that contains a pressurized mix of propellant gas and the medicine. And the gas has to disperse the medicine into particles fine enough that can be easily inhaled down into your airways. And at the same time propel the medicine at a consistent speed when the button is pressed. And it has to achieve that in a highly consistent way for the first dose when it's completely full, all the way through to the 200th dose when it's nearly empty. So it's a brilliant piece of technology, but unfortunately, the only way we've found to do this so far involves using propellant gases, which are highly damaging to the environment. Why should we care about the climate crisis? Well, there are loads of brilliant talks on this on the website, far better than I could deliver. But fundamentally, I agree with many of the previous speakers that the climate crisis is a health crisis. And I would recommend the Lancet Countdown on Health and Climate Change if you've not read it before. Healthcare systems are also a major contributor to greenhouse gas emissions. And I do think we have a duty to show leadership on this as a health crisis and do everything we can to safely minimize greenhouse gas emissions as soon as possible. But we're also well positioned, as other speakers have pointed out, as trusted and caring individuals to repeatedly communicate clear and simple messages about the climate crisis. Another reason is that your feet might start getting wet. I've not been to Boston, but I understand these predicted flood areas by 2070 are knocking on your door. We've seen it in London already with hospital care disrupted by flooding. Other examples include these horrendous wildfires, which are obviously made much more likely by climate change. The fires themselves release even more carbon dioxide, and they wipe out woodland, which is sometimes being used as an excuse for other greenhouse gas emissions, including by the pharmaceutical industry sometimes, if they're being counted as carbon offsets. But they also create huge clouds of air pollution, which impacts health in other myriad ways. The greatest impacts are of course, felt by those who don't make the headlines, the poorest and most vulnerable in society, particularly women and children, and particularly those people living with pre-existing health conditions, including asthma and COPD. But the story for medical propellants and the environment begins not with a climate crisis, but with the ozone layer. And it was back in 1974 with a really planet-saving publication that Mario Molina and Sherwood Rowland described the exponential increases in CFCs in the stratosphere, which catalyzed breakdown of stratospheric ozone with potentially devastating consequences for life on Earth. Further research followed, including airborne studies identifying the role of chlorine chemistry in ozone destruction and the hole in the ozone layer, which turned out to be much bigger than anyone had predicted previously. The ozone layer, of course, protects us from the sun's harmful UV rays, which cause health problems, most notably skin cancer and cataracts. And as a consequence of this, in 1987, the Montreal Protocol was signed initially to reduce CFC emissions, but subsequently was strengthened several times in response to more emerging evidence of the harms of CFCs. And thus, the exponential, irreversible, and long-term increases of stratospheric CFCs were prevented. And this was a brilliant example of cooperation on an international scale to overcome a potentially disastrous environmental catastrophe. And most of the CFCs were used in the refrigeration and air conditioning industries and foam blowing, but also spray propellants, including in CFC, in metered-dose inhalers. And the metered-dose inhalers were initially exempt from Montreal Protocol because they're such an essential item for patients. But following massive $2 billion investments and 20 years of work from the multinational drug industry to reformulate them, CFC-free metered-dose inhalers were developed. And as a consequence of this agreement, the ozone layer is predicted to recover around 2060. And unfortunately, because the impacts of UV radiation on skin add up over a lifetime, the following consequences for human health will continue for another 40 years. But CFCs are also extremely potent greenhouse gases, far more potent than carbon dioxide. And without the Montreal Protocol phasing out and banning CFCs, it's been estimated that we'd already be locked into about 3 degrees of global warming. So that's great, we've fixed the problem, haven't we? Well, unfortunately not. We've made massive progress in getting rid of CFCs, but the propellants we've replaced them with are still very powerful greenhouse gases. So I'd like to just introduce the concept of global warming potential of a chemical, or GWP, which refers to how powerful a greenhouse gas is relative to carbon dioxide. So the GWP of CO2 is by definition 1. CFCs listed at the bottom that were used in inhalers had global warming potential of 4 to 10,000 times that of CO2, but the inhalers, the propellants we've replaced them with, are still 1 to 3,000 times more powerful than CO2. And I've included a couple of other ones on there, the HFO at the top and HFA 152A, which are promising candidates for replacements to the currently used propellants. And I think it's fair to say that remain significant uncertainties to how powerful these greenhouse gases are, and this often introduces the biggest potential error in carbon footprinting studies of metered-dose inhalers. But due to many factors, including revised estimates of the lifespan of these chemicals in the atmosphere and their radiative efficiency, the most up-to-date figures from IPCC AR6 show these gases to be significantly more potent than we previously thought. And anything you've previously heard about the carbon footprint of metered-dose inhalers, you can probably add about 11 to 18% to it, and that will give you a more accurate figure. Including this figure here, which really needs updating by adding everything 11 to 18%. This includes all the published peer-reviewed studies of inhaler carbon footprint that I'm aware of. And I've got to caveat this a lot. I was saying to people earlier, I'm quite worried about being sued at one point for talking about carbon footprint of inhalers, not because I'm not confident in the data, but because the sums of money involved are so huge. But these are really indicative carbon footprints of inhalers currently used in the US, based on studies from the UK and EU. And I think I'm growing in confidence in this data, in large part because the vast majority of the carbon footprint comes from the propellant gas. 92 to 98% comes from the propellant gas of all meter dose inhalers. And there are lots of life cycle analyses showing that now. So it really is all about the propellant. And a couple of things to draw from this are that not all meter dose, or not all inhalers are meter dose inhalers. Dry powder inhalers instead don't have a propellant. They rely on the patient's breath to disperse and propel a very fine powder of medication into the airways. And as you can see in the grey bit towards the bottom, they have a much smaller carbon footprint. Similarly, soft mist inhalers use a spring to drive a watery mist of medication into the airways, and they're refillable, so they can come with a really tiny carbon footprint, up to 100 times less than some of the meter dose inhalers. But there are also significant difference between different sorts of meter dose inhaler, depending on the amount and type of propellant they use. So Symbicort at the top uses HFA 227EA propellant, which, as we saw on the last slide, is about 3 times more powerful than HFA 134A, which is used in most other meter dose inhalers. But Ventolin uses a very large volume of HFA 134A, and other generic salbutamol use a co-solvent, so much lower volumes of propellant are needed to create the drug suspension. And I've included a couple of hopeful potential future meter dose inhalers there as well, which will be a massive change, massive improvement from current inhalers. But there's quite a lot more work to do first. And remember that they've switched from CFCs to HFCs, took about 20 years to achieve. So thinking about how the different types of inhalers are used globally, this is just some data I've drawn from a range of slightly different sources, just to give an idea of patterns of inhaler use globally. And some of the data looks as percentage of devices, others look at percentage of doses. So there are slight discrepancies there, but you can see there are huge disparities from 90% MDI in many countries down to as low as 13% in some of the Northern European countries. And whilst it's difficult to draw any firm conclusions from this, I would argue that many of the European countries outside the UK who are leading the way in terms of low asthma mortality are using a pretty small proportion of meter dose inhalers, using much larger proportion of dry powder inhalers, which of course are much more environmentally friendly as well. And I think at very least this makes it hard to argue that the high rates of meter dose inhaler use are helping patients very much. So let's move from global to a national healthcare system perspective. And the UK is a bit of an outlier compared to the rest of Europe in its very heavy reliance on meter dose inhalers, but perhaps not that different to the USA. And in the UK, meter dose inhalers contribute 13.1% of the NHS's carbon footprint. A lot of the data says 3 to 4%, but that looks at carbon footprint plus, which is everything the NHS can influence, including supply chains and how visitors come to visit the hospital. But if you look at the NHS's core carbon footprint, it's 13.1% of that. And NHS England has set a target for reaching net zero by 2040, of which the shift to low carbon inhalers is really important, more significant than other key efforts like electricity decarbonisation, on-site renewables, or electric vehicles, for instance. And most of the carbon footprint comes from the blue short-acting beta agonists, salbutamol, albuterol, as you call it, in the US, Ventolin, the most common brand. This is market research data from European countries, showing firstly that in all the countries, these blue SABA relievers constitute most of the inhaler sales and most of the carbon footprint of treatment. And we see in the UK a very high reliance on reliever inhalers, where our European neighbours use a greater proportion of DPI maintenance or controller therapy that aims to get the disease under control rather than just respond to breakthrough symptoms. But because these blue relievers are used so commonly, you can see huge changes in the carbon footprint of treatment simply by swapping brands of blue reliever data. So this is data from England over the last 4 years, looking at the carbon impact per salbutamol prescribed. And you can see it stayed very stable at about 24 kilos per device for many years. But in 2022, some incentives were introduced to reduce the carbon intensity of salbutamol, mainly achieved by switching from Ventolin to other brands or generics with a smaller amount of propellant. And you can see in the image of the inhalers there, just the differences in the canister size that reflects the differences in the volume of propellant. And the greenhouse gas reductions that have been achieved by doing this are huge. So 12,700 tons a month in England alone. And even if we plateaued completely from this point, this would be equivalent to the carbon emissions from taking 33,900 cars off the road, according to the US EPA website, which is roughly equivalent to 70,000 of our funny little European cars. Let's move now to a disease. Let's look at asthma for a moment. So asthma is extremely common globally and affects nearly 26 million people in the US. And it's driven to a large extent by the quality of the air that we breathe, being made much more likely by air pollution, which in turn promotes the development of allergies. Occupational exposures are very important, as is smoking, either directly or as secondhand smoke. Other factors such as obesity and antibiotic use make asthma more likely, whereas other factors may be protective, particularly breastfeeding. Pathologically, in an asthmatic airway, we see a combination of airway inflammation when exposed to triggers and during exacerbations, we see airway narrowing as well, bronchoconstriction due to tightened airway smooth muscles. And I think it's important patients understand this. Incidentally, I no longer talk to patients about inflammation because, let's face it, having a disease with inflammation doesn't sound very sexy, does it? And people don't really want to think about that, and they don't want to think, and then they don't want to think about their treatment. So I talk about the airways responding too strongly to things in the environment, because being too strong sounds a lot better. And I talk about the need for using extra steroids through an inhaler. Steroids are something that the body produces naturally because people like a natural solution. And you need a bit extra steroid because your airways are responding too strongly, and that can restore the balance in your airways. And this way of talking about asthma was based on the work of Professor Rob Horn in what he calls the asthma balance model, which I think is a much better way to engage patients in talking about asthma. Anyway, if we consider the carbon footprint of asthma treatment, the overall carbon footprint of a disease, this graph shows the carbon footprint of different aspects of healthcare provided to asthma patients in the UK. And it's derived from about 500,000 primary care asthma patients with linked hospital episode data. And the blue section shows the carbon footprint of the SABAs, the short-acting beta agonists that open up the airways, mainly Ventolin in the UK. And the brown section shows the asthma controllers, which are used to settle airway inflammation. In the UK, mainly beclomethasone meter-dose inhaler, but other combination inhalers are used as well. Now, the other tiny slithers show the carbon footprint of other aspects of asthma care, like the oral steroids, but even hospital stays, intensive care stays, routine asthma reviews, all the primary care provision. So I think two main points from this graph. Firstly, the carbon footprint of asthma is about 3 times greater when asthma is not well controlled compared to when it is well controlled. And secondly, the large majority, about 90% of the carbon footprint, comes from the inhalers. And the US, on the face of it, doesn't appear to be that different to the UK. A very high proportion of US inhalers are meter-dose inhalers. So slightly different data sources, but it seems to be about 80%. Your per capita use of inhalers is a lot lower than in the UK, perhaps due to the cost and access issues for some patients. But it's increasing fast, and albuterol relievers represent about 60% of the meter-dose inhaler market in the US. And here's just some published data on the real-world management of asthma in the US based on different insurers. And about half the patients with asthma are treated with bronchodilators only. That's the SABA only group. About a sixth using a separate inhaled steroid, that's the ICS, inhaled corticosteroid as well, and about a third are on combination inhalers. But these patients do not have well-controlled disease. Many of them, 46% in US Medicaid, are using 3 or more blue relievers annually, which is a recognized marker of poor control. And over 40% have 1 or more exacerbations in the last year. So these are all patients who really ought to have their controller treatment escalated, who should not be on SABA-only therapy. We've known for a long time that patients who need a lot of these SABA reliever canisters are more likely to require hospitalization or oral steroids, with the risk increasing beyond 2 canisters and rising as more canisters are needed. And you might say, so what? You know, people with more severe asthma take more treatment. Well, that's hardly a surprise. But the opposite is true for inhaled steroids. So the more inhaled steroids you take, the less likely you are to die from asthma, and the less likely you are to suffer an exacerbation. So now the question becomes, how can we support asthma patients to take the anti-inflammatory medication to restore the natural balance within the airways? And would that then reduce the environmental impact of their treatment? Well, I think yes is the short answer. And I'm going to just run quickly through an example of a real-world quality improvement project within the NHS with 2 aims: to improve asthma outcomes for adult patients through identifying and addressing this over-reliance on blue relievers, and secondly, to reduce the environmental impact of adult asthma management. The project involves these 5 pillars: healthcare professional education on what asthma is, what the guidelines say, and what the risks of over-reliance on the blue inhaler are. Gold standard prescribing practices, which focus a lot around patients having their inhaler technique taught and assessed. Targeted asthma reviews of patients who are over-reliant on their blue inhalers. And it's really important to target these patients for review, because these are the patients who are most likely to exacerbate. They're needing a lot of their blue relievers because they've got poorly controlled disease. It was supported by a good range of patient support and education materials, and of course, rapid data turnaround on patient outcomes and prescribing practices. And because it's real world data, it is a bit messy, but the first chart, the top left, shows data from the first pilot. So pilot PCN, that's a primary care network, is a cluster of primary care practices. And there's a bit of a blip there due to practice mergers. But as you can see, the project was started towards the end of 2020, which in itself was an amazing effort, really, during COVID to implement it. And it saw massive improvements compared to pre-implementation, with reductions in the amount of SABAs that patients are using in proportion to the amount of maintenance therapy. And as other primary care networks joined, this started to have a regional effect across Hull, which has a population of about 300,000 patients overall. As part of the project, over 44,000 fewer blue reliever inhalers were used, saving over 1.2 metric tons of carbon dioxide equivalent. 1.2 thousand metric tons of carbon dioxide in greenhouse gas emissions. But the improvements are greater than that, because they go beyond the reduction in SABA into clinical benefits. And among the whole group of patients that were reviewed in the pilot PCN, there was an 8% reduction in patients having 1 or more exacerbations. So that's across the whole asthma population. Actually, only 864 actually had a review under the QI project. And of those who had a review, there was almost a 30% relative risk reduction in exacerbations. And you can see about 20% of the patients were changed to maintenance. Almost half the patients were changed to maintenance and reliever therapy. That's the green graphs on the right side. So these patients didn't have a blue SABA reliever at all, just one combination inhaler with formoterol and budesonide. And this was usually a dry powder inhaler with a fast-acting bronchodilator and an inhaled steroid to control symptoms and inflammation at the same time. And those patients similarly saw a 20% reduction in the relative risk of an exacerbation. So I think this is a great example of a real-world quality improvement project in asthma, that by prioritizing the assessment of poorly controlled patients, escalating their therapy in a systematic way, prioritizing low carbon inhalers where clinically appropriate. We can see great improvements in clinical outcomes alongside reductions in greenhouse gas emissions. So just a few summary points from asthma to take away. Most of the carbon footprint from asthma comes from the metered dose inhalers, particularly the SABA relievers. But over-reliance on reliever therapy reflects poor asthma control and results in large greenhouse gas emissions. Greater emphasis on effective controller therapy, ideally using low carbon inhalers such as dry powder inhalers, can improve outcomes and reduce environmental impact at the same time. Okay, moving on to the next big disease in respiratory medicine, that's COPD. COPD affects 16 to 24 million adults in the US, and again, it's due to the quality of the air that we breathe, predominantly cigarette smoking, but lifelong exposure to air pollution does influence your lung capacity and the airflow. 12% of adults in the US smoke, 13.4% in Massachusetts. So you're slightly ahead of us in terms of getting rid of smoking, but we're not far behind. People can get a bit depressed about the treatment of COPD as it's so common and incurable, but there are two miracle interventions that do reduce the risk of death, heart disease, stroke, depression, cancer. They are, of course, smoking cessation and exercise, but specifically in COPD, we have pulmonary rehabilitation, which is a really well evidenced and powerful intervention aimed at getting patients with COPD more active. And this is a really popular graph used in pretty much every talk in the UK on COPD, and it shows the COPD value pyramid, essentially a model designed to aid clinicians and providers to make value-based decisions for people and populations with COPD, with the most cost-effective interventions, with flu vaccination at the bottom and the least cost-effective interventions at the top. And in an ideal world, we would be much more efficient at implementing the most cost-effective interventions. In reality, in the UK, the pyramid doesn't look very pyramidal. And I've just thrown together some data from a few US studies referenced at the bottom there. And I'm not going to pretend this is particularly perfectly rigorous data. I couldn't get great figures on smoking cessation in COPD patients. But it would appear your pyramid is also pretty top heavy. And from an environmental perspective, I think there are two specific points here. Firstly, the same is very likely to be true in terms of the environmental cost of these interventions. So in general, in carbon footprinting, the carbon follows the money. So the more expensive interventions are more carbon intensive. But for inhalers, this doesn't really hold true, as we've seen, because they're propellants. And if we were to do carbon costs per QALY, the pyramid would probably look even more top heavy. But secondly, an awareness of the environmental benefits of this sort of lean healthcare delivery that prioritizes the most cost-effective, the most carbon-effective treatments as well, can help drive quality improvements. I would hate you to think that I've come here to tell you how to manage COPD and you're doing it all wrong, but that's not my point at all. My point is that implementation is difficult, and it's difficult everywhere. And implementation of the most effective and cost-effective strategies is hard, but environmental sustainability considerations can be a useful additional lever to help encourage implementation of QI projects in the real world. We definitely saw that with the Sentinel project I discussed earlier. And I see this in many of the presentations I do on respiratory care, that healthcare practitioners are motivated by these opportunities. So honing in a little bit more on smoking cessation, there's absolutely abundant evidence for the effectiveness of smoking cessation support, but delivering it on the ground is often overlooked by physicians. And it can be downheartening as patients are a bit nihilistic about their ability to quit or suffer frequent relapses. But it's important to remember that the health benefits are huge from smoking cessation. And I love this paper. Karen Mullins, the first author on smoking cessation, which examines a really intense smoking cessation intervention for smokers using a pre-implementation control group and comparing that with post-implementation results. And they found huge benefits. The graphs show an absolute risk reduction of readmissions and death for these patients, with ultimately a 6% absolute risk reduction in death at 1 year. And in the conclusions, they write that considering the relatively low cost, greater adoption of hospital-initiated tobacco cessation interventions should be considered. Wow. 6% fewer people died in the intervention group after almost half of them quit smoking. And it didn't cost very much. So, it's a real no-brainer. They achieved these very high rates of smoking cessation through intensive inpatient counselling, very generous nicotine replacement therapy provision with multiple patches used for many patients at the same time, and intensive post-discharge support. And we're trying hard to replicate this in many hospitals in the UK now, but I do think smoking cessation support along with inhaler technique assessment are two of the most important and rewarding things that I do as a respiratory physician, not just because they can have a really positive impact on patients, but also because they're great ways to reduce the environmental impact of the healthcare we deliver, not to mention the broader environmental impacts of the tobacco industry, which annually cost 84 million tonnes of carbon, result in 600 million trees being chopped down to grow tobacco plantations, but also a huge amount of waste from tobacco, from cigarette filters polluting the environment. Let's hone down even further now to a real life patient example. So this is a 77-year-old man who I met in hospital after being admitted with a COPD exacerbation, and he had quit smoking about 6 months previously as his breathlessness seemed to be worsening, but he hadn't done pulmonary rehab before. And I said, show me what you do with your inhalers, which I think is a really useful question for respiratory patients. It's infinitely more useful than asking, can you use your inhalers okay? Because all patients think they can use their inhalers okay. And he had incredibly poor inhaler technique. He lined up his 3-meter dose inhalers, the flutiform, the ipratropium, and the Ventolin. And he picked the first one up and he went, and he did this kind of double puff with a fast inhalation. And he did that with the next inhaler, and he did that with the next one. And he would do that 4 times a day for the ipratropium and Ventolin, and twice a day for the flutiform. And we worked out that he'd used 12 flutiforms, 12 ipratropiums, and 15 Ventolins in the last year, at a financial cost of £632 and a carbon cost of about a tonne of carbon dioxide. But of course, the way he would naturally use his inhalers was breathe in hard and fast, which meant he struggled to press the button and breathe at the same time. But he was also breathing in too fast to use a meter dose inhaler, which of course sprays the medicine out. So most of it was hitting the back of his throat. So we changed him to a dry powder inhaler, in this case, Trelegy through an Ellipta device, and put him into pulmonary rehab, which he really enjoyed. He'd been a boxer before, so he liked being back in the gym, and he made new social connections as well and came out of his shell a bit. But he also had a much better mastery of his breathlessness, so he didn't need to rely on his inhalers in the way that he used to. And the financial cost of his medication decreased slightly, but the carbon footprint of his treatment plummeted by basically a ton of carbon dioxide during the next year. Now, the whole issue of inhaler technique is a huge topic that I can't possibly hope to cover here, but just very briefly, this is the suggested strategy from the UK NICE, National Institute of Healthcare Excellence. And I like that it highlights probably the 2 most important factors in device selection. Can you breathe in quickly and deeply? Can you breathe in slowly and steadily? And can you reliably coordinate pressing and breathing at the same time? And according to your abilities, it advises what inhalers you might like to choose from. And now, I think in reality, most patients can be trained to use most devices. And in my practice, I would generally favour the dry powder inhalers where there's no clear reason to select any other device. But I recognise the situation is far more complex in the US, with insurers often determining which devices may be possible to use, and the direct cost to the patients can be very different as well. Giving a patient an inhaler device that they like, that they can and will use, is also really important. And all the industry-sponsored studies of inhaler preferences miraculously find in favour of the sponsor's inhaler. And that's one reason I really like this study from Germany in 2020, is it was not sponsored by industry, and the authors declared no conflict of interest. And the patients were given a really wide choice of different devices to use. They were trained to use them and then asked, which of these devices would you prefer for everyday use? And although no single device was a clear standout winner, by far the most popular class of inhalers was the multi-dose dry powder inhalers, even though before the study, most patients in the study were using meter-dose inhalers. Now, none of this study included any information on the environmental impact of inhalers, which I think is increasingly important to patients, even though most patients are actually unaware of the large carbon footprint of MDIs. And at ERS Congress in 2021, we heard evidence from over 12,000 UK asthma patients, and most, 60% of them, said yes, they would change their inhalers for environmental reasons. A further 21% said they might. So clearly there's an appetite amongst patients to move to more environmentally friendly inhalers, but also to move away from meter-dose inhaler use. And this survey was I think was a highly significant result, and I think quite unexpected by many people beforehand. It was funded by an asthma charity, but it's really changed the conversation about discussions about the inhalers and the environment in the UK, and people are much more confident now to talk about it based on this really big survey. Okay, so I'm just going to do some summary points for COPD. Firstly, the most cost-effective interventions are underutilized, but are also the most environmentally friendly. Secondly, thoughtful inhaler selection can have a dramatic effect on carbon footprint of patients' treatment. And thirdly, I didn't articulate this very well earlier, but environmental concerns can be used as a powerful incentive to drive QI projects within healthcare and to drive healthcare professional education. So what next for meter-dose inhalers? Well, meter-dose inhalers remain a vital part of therapy for many respiratory patients, particularly the very young or those patients who struggle to generate sufficient inspiratory flow to activate dry powder inhalers. They may be more cost effective in many parts of the world as well, although single dose DPIs where you put a capsule in can also be extremely low cost and actually more affordable because patients can buy 1 or 7 doses at a time rather than having to afford all 200 doses in one canister. And that's one of the reasons they're more popular in some parts of the world, such as India. The development of new propellants is well underway with 2 potential candidates, HFA-1528 and HFO-1234ZEE, and both have far smaller carbon footprints than meter-dose inhalers, as you can see in the graph here. So the good news is they're showing great promise in preclinical studies, and significant financial investments have already been made, in large part because the refrigeration and air conditioning industry are moving away from current propellants already. And one of the reasons meter-dose inhalers are so cheap is because propellants are produced in bulk for refrigeration and air conditioning, and all you have to do to make a meter-dose inhaler is purify that and put it in the canister with a medicine. But now the refrigeration and air conditioning industry have moved away. The bulk cost is increasing, and that's driving. That's a big financial pressure for the pharmaceutical industry to find alternative propellants, and thankfully they're moving to those with a much smaller carbon footprint. I think the bad news is we're not really using the currently available options. The most obvious example in the US being probably Symbicort dry powder inhaler, which I would say is the best evidenced inhaler in asthma, full stop. And for reasons that baffle me, it's just not available. Secondly, the rising cost of these propellants could disrupt markets, and I think this is a real risk. Access to medicines is very tenuous in many parts of the world, particularly low-income countries. But I know in the US you had issues with albuterol supply recently as well. And if you look at the new propellants, there's only 2 manufacturers, Quora making HFA-1528 in the UK, and Honeywell making HFO 1234ZE in the US. And there remains significant uncertainty about which propellant we should go for. HFO 152A has a higher global warming potential than the hydrofluoroolefin, and subsequently a bigger carbon footprint. But recently there have been concerns about the PFAS, the forever chemicals involved with HFO 1234ZE. Even from that perspective, it's a significant improvement over 134A, but it's just creating a bit of uncertainty in the market, and the generics and the other manufacturers are standing back, waiting to see what happens next before jumping in to produce a lot of these inhalers. Okay, this is my last slide now, and I just wanted to try and draw out a few conclusions, but also open up the discussion a bit more. I don't know if you've ever had this, but just occasionally you come across a paper that changes your life, maybe just your professional life. Perhaps I'm a bit nerdy. Some of these have changed my life completely. And for me, there have been two big ones. One was a short letter to the BMJ from about 10 years ago, where I learned that metered-dose inhalers have such a huge carbon footprint. The second one was this by Dr. Francis Mortimer from the Centre for Sustainable Healthcare in Oxford, and it describes the 4 principles of sustainable clinical practice, all of which I've really mentioned already. Firstly, disease prevention and health promotion, and in particular with respiratory care, I've talked about the importance of smoking cessation and exercise. Secondly, patient education and empowerment. And I've touched upon some of the best ways, I think, to talk about asthma, to help people understand their disease. Because if a patient doesn't know how to use their inhaler, or why to use their inhaler, or can't use it, then clearly it's a total waste. But if they can understand their disease and understand how to respond to deteriorations, then they can get better control over their disease and often manage it themselves in a much more efficient way. As physicians, we maybe see patients with asthma for half an hour a year, but the rest of the year, the patient's got to look after it themselves. So it's vital they're empowered to do that. Thirdly, lean service delivery. And I've discussed how environmental concerns can help drive the most cost and carbon effective strategies, looking at the COPD pyramid. And finally, considering low carbon technologies of treatments, of which the dry powder inhaler or the soft mist inhaler represent a pretty extreme example, with 100 times lower carbon footprint than some metered dose inhalers. But hopefully we'll soon be able to add other metered dose inhalers with novel propellants to our list of technologies with a lower environmental impact. By harnessing these principles, we can improve the quality of care that we deliver at the same time as reducing environmental impacts and improving patient outcomes. Thank you.
Thank you so much, Dr. Wilkinson. I just wanted to say that was, well, first of all, that was a tremendously informative talk. Like I mentioned before, I have read much of your work, and even so, I think I just learned a huge amount from your presentation. So I really appreciate that. I wanted to open it up for some questions. I have one myself that I was hoping to start with, and then we'll take some from the audience as well. But I'm curious if you have a sense of why the relative proportion of use of metered dose inhalers versus dry powder inhalers is so different amongst different countries, but even in Europe. So what historically has led to countries like Sweden using such a lower proportion of metered dose inhalers?
Yeah, I don't really know, to be honest. I mean, I think in Sweden, AstraZeneca have had a big influence with their Symbicort dry powder inhaler, which of course, historically that's been their big, massive, successful product. I mean, in the UK, we used to look quite a lot like the rest of Europe. If you turn the clock back about 25 years, we were mainly using dry powder inhalers, and we've over the last 2 decades, we've had a massive swing over to metered dose inhalers. And I think it's been driven by cost. Well, efforts to reduce the cost, but really just focusing on the upfront drug cost, because we've seen evidence as it's been done that health, asthma controls deteriorated as patients were switched to metered dose inhalers, often with no inhaler technique education alongside it, which that's always a bad idea. Switching someone's inhaler device without making sure they can use it, without assessing their technique, is always a bad idea, and we saw that a lot in the UK. But yeah, the global differences are really interesting. I mean, I mentioned a bit about affordability. That seems to be a big thing driving the single dose DPI inhaler use in parts of Asia, because patients can just buy one dose or 7 doses at a time. But why US, Australia, Canada have such high use of MDIs? I don't know. The US market in particular is baffling.
Yeah, I'm sure it probably has a lot to do with money in the United States. But
yeah,
I may ask just one other quick question. So in terms of recommendations for those of us practicing in the United States, so obviously international guidelines and even guidelines from our own kind of from the NIH in the US are recommending switching to single maintenance and reliever therapy, which leaves those of us in the United States stuck with this kind of conundrum of switching patients to a Symbicort meter dose inhaler, which, as you mentioned, has a more potent propellant from a global warming potential standpoint, but with the idea of achieving better disease control, versus an alternative, which would be to have someone use a dry powder inhaler, steroid, and potentially a dry powder inhaler, SABA. But that makes it really complicated for patients. So I'm curious what you might recommend given the limitations that we face. I know what my own kind of practice has been, but I'm curious to hear what you would suggest.
Yeah, I mean, it's not a one-size-fits-all solution. That's certainly what we saw in Sentinel's project. That the inhaler changes were driven by what can the patient use, what's the patient want, and I do think that has to be the first priority. We saw of those reviews, they did prioritize moving patients away from Ventolin to combination therapy. I think if you switch people from, Ventolin's got a big carbon footprint as well. So if your patient's on Ventolin and you're moving them to Symbicort, I think it's highly likely you will reduce their carbon footprint as well, at the same time as reducing the overall greenhouse gas emissions. Provided that's the right thing for patient, and they're the inhalers that they can use.
Great, thank you. I'm going to field some questions from the audience here that are coming in through the chat. So, have you found particular strategies to persuade your less climate-oriented clinician colleagues to move in this direction?
Well, I think when I first started talking about this, I was mainly talking about the environmental impact and saying, "Hang on a minute, what do you think about this?" I've moved away from that now and said, by combining the arguments about good quality asthma care is low carbon care. These are not, or extremely rarely are these opposing, issues. So yeah, my recommendation when talking to colleagues is talk about the two things together: improving care and reducing greenhouse gas emissions. Because I think if you don't do that, then people will put up walls and say, this is not what we're here to do.
Great. Next, so how does the different general environment, air quality, et cetera, urban versus rural, impact on patient outcomes? I think that's probably referring to respiratory outcomes in general.
So how does it, just say that again, Greg?
How does variability in the general environment. So things like air quality, particularly versus in urban versus rural, kind of influence patient results and outcomes, and how might we think about that in relationship to use of different inhaled respiratory therapies?
Yeah, I mean, it clearly has a massive impact. I mean, I think there's kind of interesting natural experiment that happened in Finland, and the Finnish story is really interesting. Finland's not a big country, but they've got a really well advanced asthma management program. And at the start of it, what they realized was that if you look at the rates of allergic disease in Finland, if you go over the river to Russia, you can't really do much science there at the moment, but when they did it 20, 30 years ago, they saw why we've got this huge increase in allergies in Finland, more developed, richer country. Why are we seeing that? It's hard to pin it down to particular things. Clearly air pollution is one of those and a major factor. But they've introduced, a really holistic approach to trying to improve the environment to improve asthma outcomes. And Finland, I mean, it's a beautiful country. There's a lot of green space there, not a lot of people. And the solutions went from encouraging breastfeeding, reducing overuse of antibiotics, monitoring and reducing air pollution, introducing plants into schools and preschools and nurseries to try and improve the air quality there. Getting rid of the, using the hygiene hypothesis. So getting away from saying, okay, some kids are allergic to nuts and strawberries. No kids can have nuts or strawberries ever. And just saying, okay, we're going to expose you to these antigens and try and reduce the burden of allergic disease that way. And specifically with asthma, for a long time, they've had a really strong emphasis on the need for maintenance therapy. They use very low proportion of reliever therapy, much higher proportion of maintenance therapy. So I think that's a really interesting example. The environment, well, to what extent does the environment influence this? The environment is this. Respiratory disease is basically due to the quality of the air that we breathe. And if we could clean that up completely, I could go home and tend my garden.
We have to finish a little bit early today, but I just want to mention this one last question. I'm not sure that you are going to be able to answer it, given the fact that you are not practicing here in the US, but is the cost of meter dose inhaler versus dry powder inhalers a disincentive in the US for moving to the dry powder devices? And does Medicare acknowledge this need and adjust cost accordingly? And if you don't feel comfortable fielding that one, I'm happy to, based on my perspective, but
go for it.
Yeah, and so the cost definitely is a factor. There are relatively few dry powder inhalers in the United States that are available as generics. And so insurance formularies do dictate much of the choice that we have as clinicians. And that is kind of a barrier to prescribing more dry powder inhalers. It's also kind of the availability of dry powder inhalers. We mentioned that Symbicort, which is the most recommended medication for asthma at this point, is not available in the United States as a dry powder inhaler. Regarding Medicare, I think they're waking up to this, the fact that pricing is a barrier to being able to prescribe dry powder inhalers here, and recognizing the kind of climate benefits as well as in particular and disease control benefits of this transition. But I wouldn't say they are doing much actively at the moment to really change their practices and their reimbursement. We're hoping that's something that will change, particularly through advocacy, as we educate more people about the importance of this. So as I mentioned, I think we're going to try to end a little bit early today. So I just wanted to once again thank you, Dr. Wilkinson, for speaking to us. This was really tremendously informative, and we're really appreciative for you taking the time, particularly from the other side of the pond, as you would say. And for those of you in the audience, there will be a link to the recorded version of this as well that will become available soon, in case you weren't able to catch the entire presentation. So thank you again. We hope to see you all next month.
Thanks very much, Greg.
Bye now.
Bye-bye,
Take care,
everyone.
Alex.